Thank you all for joining us today. I see, in addition to a lot of Duke folks, I see a bunch of UNC colleagues, so it's good to see your faces and some RTI folks. So definitely happy to see you here. Brenda and Gregory, the UNC CFAR, and you may know this, has partnerships with RTI and FHI. And so earlier I mentioned to you that UNC would be here, and then also the RTI is part of that collaboration. So I'm very happy to see all of you. My name is Amy Corneli, and I am the director of the Social Behavioral Sciences Core of the CFAR at Duke. And I'd like to introduce the two speakers to you today. Dr. Brenda Curtis is an investigator with the Translational Addiction Medicine branch at the National Institute for Drug Abuse Intramural Research Program. Her research focus is translational, leveraging big data methodology to form the development, evaluation, and implementation of technology-based tools that address substance use and related conditions. She uses this methodology to facilitate the flow of scientific discovery to practical applications, allowing one to reach underserved populations and to design health monitoring and behavioral change interventions that are user-centered, inclusive, and evidence-based. Currently, she is co-chair of the NIH Stigma Scientific Interest Group. Dr. Gregory Greenwood is the branch chief of the Developmental and Clinical Neuroscience HIV Prevention and Treatment branch in the Division of AIDS Research at the National Institute of Mental Health. He continues to serve as program officer of the HIV Testing and Social Determinants program. As branch chief, he provides scientific and technical leadership on the strategic planning activities and scientific research initiatives of the branch. As program officer, he oversees a program focused on HIV testing and social determinants of HIV prevention and treatment, in particular intersexual stigma and discrimination. Dr. Curtis and Greenwood will provide an overview of the Stigma and Discrimination Toolkit, recently developed by NIMH and NIDA in partnership with Fogarty International Center and NIH Stigma Scientific Interest Group. And they will discuss stigma research findings and priorities for NIDA and NIMH. We'll also post their full bios on our website, as well as information about this meeting and recording of it. Thank you both for your willingness to join us today, and feel free to put in questions in chat that you have, and we can bring those up, or feel free to ask questions along the way. All right, thanks so much. Take it away.
Great, thanks everyone, and thanks to the organizers for inviting us. And thank you for taking part of your busy day to join us. As just mentioned, both Brenda and I are co-chairs of the NIH Stigma Scientific Interest Group. Brenda represents the intramural side, and I represent the extramural. Next slide, Brenda. So just a quick overview. Before we get into the toolkit, we thought we would set the stage for providing you an overview of some of the stigma research, stigma science, NIH activities that really led to propel us to develop a toolkit and disseminate, post it publicly. We will mention a stigma commentary led by our NIMH, NIDA, and NIAAA Institute directors. We'll take a look at the toolkit itself. And then along the way, Brenda will be able to interweave some of the research that she's leading in her intramural research program. And then we'll end with a view of some of the NIMH and NIDA extramural research priorities as it relates to stigma. And then spend some time for question and answers at the end. Next slide.
Hello, everyone. In kind of thinking about how we approach stigma and what the research that we're doing and the work we're doing at NIDA and NIMH, we have to think about stigma as a powerful social process of devaluing people or groups of people based on real or perceived differences. Stigma is defined as an attribute that links a person to an undesirable stereotype, leading other people to reduce the barrier for whom for whole and usual person is tainted and discontinued. And discounted. One of the areas that I've been doing research on and groups have been doing research on is how stigma dehumanizes someone and how it allows for us to not only to label a person, but then also to discriminate against them, to deny that person or that group full social acceptance, to reduce opportunities, and it's kind of like a societal reduction of opportunities. And all of these things, it fuels social inequalities. CDC defines social determinants of health as a social condition that influences health of people and communities. Stigma research has traditionally emphasized studying people with unusual conditions. Initially, things like leprosy and, mental illness, and then, moving to HIV/AIDS and substance use. By contrast, research focused on prejudice and discrimination tend to focus on far more ordinary, but clearly powerful implications of things like gender, age, race, and class divisions. Many researchers have concluded that the social processes of stigma and prejudice are quite similar. Both are socially structured processes that are unfair or unjustified and harms individuals and groups. The impact occur at both the structural and the individual level. And research in prejudice tradition grew from concerns with social processes driven by exploitation and domination, such as racism, while work in the stigma tradition has been more concerned with processes driven by enforcement of social norms and disease avoidance.
So thanks, Brenda, for that overview. It's important to highlight several NIH events related to HIV stigma and cross-cutting stigma that set the foundation for the toolkit. And in addition to some of these NIH events, a number of events in 2020 really coalesced to bring us to this point. So very quickly, the HIV-related stigma has been a priority of the Division of AIDS Research at NIMH since the beginning. It really started to gain some momentum in 2013 when NIMH, the Stigma Action Network, the UN Program on HIV/AIDS, and the STRIVE Program Consortium sponsored a special issue in JIAS, Global Action to Reduce HIV Stigma and Discrimination. And that really provided a great foundation, a scientific foundation for a number of areas that are described in the toolkit. For example, a systematic review on interventions and review of measurement issues. In 2016, the White House Office of National AIDS Policy, the NIH Office of AIDS Research, and NIMH came together at the White House for a meeting focused on HIV-related stigma. And it was during that White House meeting that community and others were really bringing forward the importance of not only HIV-related stigma, but intersectional stigma and intersectional discrimination. Next slide. So in 2017, really under the leadership of Fogarty brought together a number of researchers from LMICs and the US, policymakers, implementers, and we started to think about more cross-cutting stigma issues, trying to move the field where we had really been siloed, focused on HIV stigma or mental illness or drug use, and trying to think more from a cross-cutting standpoint. And so one of the subsequent deliverables from that workshop was this BMC Stigma Medicine collection in 2019, which really is a terrific collection of articles if you haven't ever seen it. And it really provided the building blocks for this toolkit. Number of articles are featured in the toolkit that in our toolkit. Next slide. So 4 quick articles, the Health Stigma and Discrimination Framework, and I'll turn to that next. There's a great systematic review around multi-level interventions, around measurements and interventions, and intersectionality. Next. The health stigma and discrimination is really, I think, a very important conceptual framework to think about health-related stigma. you'll see, and this is Ann Stengel and colleagues' article from 2019, that within a socio-ecological context, you have drivers and facilitators of stigma that impact stigma marking, impact manifestations, both of experiences and practices, which impact individuals, populations, organizations, and institutions. And it's a very helpful framework to help guide research, policy, and interventions. Next. So in 2020, there were a number of events that kind of occurred simultaneously, and I'll talk about a few NIH planned activities, including a workshop that we hosted and the formation of the scientific interest group, and some of the political civil unrest as well. And Brenda will talk about COVID-19. So you might know that the NIH-OAR and NIMH sponsored a workshop in 2020, trying to really move the science forward around HIV-related intersectional stigma and discrimination. And you'll see on the left that we have available on our website the webinars, the first from the July 13th opening session, which really set the stage in terms of conceptual measurement interventions as it relates to intersectionality in the July 13th webinar. And then over the summer, offline, there were several work group discussions. And then we came back together in September 18th, 2020 for a report out session. And that's that second webinar link where we heard from the work group members their ideas and recommendations about the theory of intersectionality applied to HIV stigma, measurement, and interventions. You'll see there's a link to a full workshop summary that includes all three phases. And you might want to know that NIH-OAR and NIMH is sponsoring a special issue that will be published in the American Journal of Public Health that will be available either the end of May or early June of this year, and that we will be looking to launch and disseminate this special issue at AIDS 2022, so stay tuned. Next slide. In the midst of our workshop, we really experienced the horrific murders of George Floyd, Breonna Taylor, Ahmaud Arbery, and countless others. I'll click on the next slide, Brenda, there you go, thanks. And the former NIH director, Francis Collins, on June 10th, put out this tweet, and I just want to call out that first line that Dr. Francis said. I call on myself and everyone who is part of the NIH community to do what we can to ensure that we foster a culture of inclusion, equity, and respect for one another. Next slide. And so in the midst of the workshop, in the midst of the unrest, our scientific interest group was launching, and we were bringing together both intramural, extramural researchers really across 14 plus institute centers and offices, with an eye towards what are the cross-cutting, what are the theoretically driven research issues around stigma, how do we think about measurement, what are our understandings around mechanisms and pathways, and how do we intervene not only to reduce stigma, but improve outcomes. And so we started engaging in a series of conversations through the scientific interest group leading to this toolkit. I'll turn it to Brenda next.
So one of the, that happened to everyone, we had the scientific interest group, and right after the start of that, we were, at the beginning of the start of that, we were hit with COVID. And when we, kind of think about stigma and COVID, it became very clear very early that we were having some problems with health disparities, and different groups were being marginalized, and different groups were being impacted by COVID. And when we think about stigma in the context of health, the negative association between a person or group of people who share a common characteristic or a disease feature. And we all were very aware of how when COVID hit, the groups which were immediately stigmatized. When we think about a disease which was novel, and we had a complete information vacuum No one knew, we didn't know the severity of it. We didn't know, there were lots of fears around it, high levels of anxiety. We were in our houses. We had limited knowledge about the disease. And it immediately led to what we've seen in the past, which are stereotypes, discrimination, labeling towards people with the disease or people that we think would carry the disease. These discriminatory behaviors, which fostered isolation and refusal to provide services, harassment, bullying, harm, were experienced by stigmatized group. The COVID-19 pandemic has been instrumental in creating a dramatic shift from people's needs to live in the mutual isolation toward a desire to stigmatize distinction of others. The pandemic seemed to be causing this level of othering of, us versus them. And we saw this a lot with stigma with COVID-19. And one of the areas that, my lab, we decided to take a look at this, to research this. We already in our lab, my lab, we do lots of work around national surveillance. I think that's a nice way of saying it. We do a lot of, not censoring or monitoring of people of social media, like Twitter feeds. We also collect social media language and smartphone sensor information around people which are in treatment, of course, with consent. One of the things we have there's Twitter allows you to collect a random sample of tweets. And one of the things that we saw early on was a lot of misinformation and really hateful speech, stigmatizing as well as hateful speech relating around COVID-19 and people of color. So one of the first things we did was we did a study in the field to look at COVID-related victimization, racial bias, mental health among Asians, Black, and Latinx US adults. And this right here study was, a direct look to try to figure out what was going on during the pandemic and how people were experiencing it. The social determinants of health and the fundamental cause of population disparities framework is what we use. And it calls for research that increases our understanding of how the circumstances in which people work and live within their context are racially based and stigma are detrimental consequences for mental health. It's not moving. Oh, wait, now it's moving too fast. Hold on. Okay. There we go. In the study, we had 401 participants who are age 18 to 72 who participated in a national online survey that we conducted during October 2020 and June 2021. We measured things like financial health, mental health, disruptions in employment, coronavirus-related victimization, racial bias, depression, anxiety, substance use, the typical mental health measures. We found that 16.5% of participants reported at least one type of coronavirus victimization, and that broke down by 27% Asian, 10% Black, and about 14% Latinx. Asians were significantly more likely to report such experiences, and young adults were significantly more likely to report at least one COVID-related victimization experience. And also pandemic-related unemployment changes to stress was positively associated with COVID victimization and COVID racial bias, as well as housing disruptions and were directly related with COVID racial bias. Approximately 27% of participants met criteria for moderate depression and about 29% met criteria for anxiety. Young adults were more likely to reach criteria for moderate depression compared to older adults. And Latinos reported significantly higher levels of depression than Blacks. There were no gender differences on either of the mental health measures. We also saw that COVID victimization, COVID racial bias, and people having at least one COVID-related health risk, and this was the CDC definition of COVID-19 health risk, they experiencing also people who experience employment changes or housing disruptions were all positively related to depression and anxiety. age, household income, and education were negatively associated with depression and anxiety. And one of the things, as in seeing what was going on with COVID and stigma, as well as the language that people were using, the NIMH, NIDA, and NIAAA directors did a publication on stigma and language. And one thing to notice is that it's really typically hard to get this types of consensus, but the three directors came out and made a statement, and they talked about mental illness and substance use disorders. You know, they've always been very stigmatized health conditions. Whenever we do studies, either in the US and outside the US, those two conditions are always one of the top 4 of the most stigmatized conditions. But despite this, over the last few decades, we've been educating healthcare providers and, you know, people in public health about the underpinnings, the neurobiological and genetic underpinnings of these conditions. But even though we're doing this, stigma persists. And our efforts to reduce stigma are considered extremely important. Stigma is causes a barrier to care, and especially for people who have mental illness and people with a substance use disorder. One of the things that we see is that people with a substance use disorder, majority of them, when asked why are they not in treatment, stigma is always one of the, or, you know, the stigmatizing condition of being a quote unquote, you know, person with a substance use disorder is one of the top 3 reasons which are given.
Great. So thanks, Brenda. So I would say that the COVID-19 pandemic and a lot of attention to COVID-related stigma and a lot of individuals coming to us, coming to folks like you, perhaps others in the field, really asking how to apply lessons learned from stigma discrimination research to what we were all experiencing with COVID-19. And that was really the thing that finally pushed us to say, let's develop a toolkit. Let's develop something that may provide a resource. And let's do it in a way that we can not only apply to COVID-19, but also start creating the building blocks for a toolkit that might have more cross-cutting purposes. And so you'll see on this first page that the Stigma Discrimination Research Toolkit, the toolkit was designed in partnership with NIMH, with Fogarty, NIDA, and the Scientific Interest Group. We will be adding other institute centers offices from NIH, but we felt a certain need to try to get the toolkit through the clearance and approval process. There's also a disclaimer, and that is, this is really for informational purposes only. It's not comprehensive, and it does not constitute an endorsement by NIMH, Fogarty, NIDA, NIH, and so on. So the institute directors were very supportive of us putting this toolkit forward, but they also wanted to make sure that the purpose is information sharing. Next slide. And so as we thought about the toolkit, and as we thought about what might be needed now and what might be useful moving forward, this is the structure, the basic structure of our thinking to date. That the purpose will be information sharing, and we try to essentially just link to published research. The landing page is designed to really be just broad and general, provide a background around stigma theory, definitions, and some of the language considerations that Brenda was just speaking about. The research tool tab is meant to, again, be more general, broad, with a focus around frameworks and models and measurements and interventions. And then we would start developing special emphasis tabs. And we started with COVID-19 stigma, and that's the tab that's currently available. And so for each tab, the idea is that we would apply general frameworks, measurements, interventions, or we would showcase frameworks, measurements, interventions as applied to that specific area. So in development, we hope to have tabs on mental illness stigma, drug use, HIV, epilepsy, cancer, and so on. And then the final page is really just trying to provide additional resources. Next slide. And so the landing page on the Stigma Discrimination Toolkit, what you'll see is you'll see just basic information about stigma, basic information about background for stigma, as well as some of the language guides. And I will turn it to Brenda now.
It would help if I unmute myself. This is something I always, we always kind of talk about, and it's the joke at my institute, words matter, and the word choices that we use matter. How we decide to label something or someone or behavior, it tells a lot about what we internally feel about it, our implicit and sometimes explicit biases that we hold. And this reminds me of an article that Nora Volkoff, my institute director, wrote. And she so eloquently put this. This was in 2020 in New England, oh, there it is, New England Journal of Medicine. And where she says, I just pull a quote here, while considerable progress has been made in recent decades in reducing the stigma associated with some psychiatric disorders such as depression, such change has been much slower in relation to substance use disorder. In this article, she goes on to discuss the impact of stigma surrounding SUDs and related behaviors that they're having in our community. And I kind of like to say, I study language, and people, sometimes think, language, why language? Well, language is how we communicate to each other. Language is the basis of therapy and a lot of our treatment. But the other thing that, I kind of mentioned earlier is that language about how we discuss a disease and how we discuss a condition or we talk about it, it has many impacts. One, it has impact on help-seeking behaviors. If you don't want to be that label, then you don't get diagnosed. You don't go to find out if you have that disorder, or you're so afraid of it and you're afraid of getting treatment. So then people are less likely to get treatment early on. Treatment sometimes then it goes until when it's like the very, nothing else can happen but treatment. Also, it impacts treatment outcomes. And that's one of the things that my lab we're really looking at is how the words that we use and how implicit bias and stigma impacts our treatment outcomes. As far as if a person believes that their substance use disorder is a moral failing, they're going to address, or a relapse is going to mean something very different to them than someone who may believe that substance use disorders are a disease of the brain, of the, the neural reward system, and it's a chronic disease that, relapses are, part of the condition. It also impacts our policies. It impacts if we are going to treat something as a disease, as a health disease or health behavior, versus if we're going to criminalize it. It also affects where we put our money. Our money is where we put our mouth is where our money is where our mouth is, the phrase. It affects, research funding, it impacts treatment, and it impacts prevention. In inspiration, I'm going to talk a little bit about my work. I'll go briefly, but the inspiration I did a set of about 7 studies dealing with language, but the inspiration comes from a piece with Kelly and Westerhoff. They started us off, and they did a study, can't remember what year, and I can't see, I think 2010, where they had, it was 516 clinicians attending 2 different mental health conferences. And so it was one conference, it was 2 conferences, and what they did was they sat outside of these mental health conferences where, these are health professionals, and there were 2 addiction-focused talks. So they stood outside these addiction-focused talks with these healthcare providers, and they provided a survey. And the survey basically, it was your old school vignette-based survey, but what was different in the survey, that people were randomized, They either were told this person was a substance abuser or this person had a substance use disorder. And then they were asked questions, the survey, they were asked questions on various character-related problems and whether the character should receive therapeutic or punitive action, if the person was a social threat, if the person was capable of regulating their substance use behavior. So again, these are healthcare providers attending a substance use disorder talk. And the main finding was that there were no differences were detected between the groups, being called a substance abuser or a person with a substance use disorder on things like social threat or victimization. However, when asked about to detect if a person was a perpetrator or punishment scale, that's where we saw the difference. Compared to those in the substance use disorder condition, those in the substance abuser condition agreed more with the notion that the character was personally capable and that punitive measures should be taken. And it's even among highly trained mental health professionals, exposures to these two commonly used words evoke systematic differences of how they were perceived. So we set off and we did a whole bunch of studies, but I'm just going to briefly talk about this one. In this one, we had nearly 1,300 people, and we had already validated, we did the vignette-based study that Kelly group did, but then we also did a go, no-go test, like a behavioral task. And we examined 7 kind of groups of words. We looked at substance abuser versus a person with a substance use disorder, addict, alcoholic. We looked at relapse versus reoccurrence of use. We looked at, opiate addict versus opioid use disorder, medication-assisted treatment versus pharmacotherapy, and medication-assisted recovery versus long-term recovery. And to summarize the findings, terms, and no one here is surprised at this, I'm sure, but terms like addict, alcoholic, opioid addict, substance abuser were strongly associated with negativity and significantly different than their positive counterparts. Relapse and recurrence of use were strongly associated, reoccurrence of use and pharmacotherapy were overall positive, and medication-assisted recovery and long-term recovery were basically the quote-unquote only positive terms that we found. What we did to get this out is we made a nice little infographic that we put all over Twitter and social media and posted online of kind of to look at the positive and the negative words, but also to look at, we acknowledge that, some places certain language is more acceptable than other. And so we gave some recommendations for how language could be used. We have moved a little bit further in the lab where we're now looking at language, as we say, in the wild or language online, real people talking language, not us predetermining words. And we've built a automatic stigma detector that can go through social media posts and alert us of more stigmatizing posts that contain negative valence as well as stigmatized language around substance use disorder.
Great. So that was a really excellent kind of deeper dive into one area of the toolkit. And so now let me finish out the rest of the toolkit, and then I'll pivot toward NIMH-NIAAA extramural research priorities. So the research tools, so again, this tab is meant to be instructive around some of the basics around frameworks, measurements, and interventions. So for example, under the frameworks, we link to the health stigma discrimination framework article in the BMC Medicine Stigma Collection, as well as a webinar where Ann Stengel describes this new framework. Other conceptual models include the stigma mechanisms and health disparities model, which is more multi-level processes in terms of how stigma gets under the skin. Bernice Pescasolido's framework integrating normative influences on stigma, which is more of a system sciences approach around stigma complex and also offers a multi-level framework approach. And And then we link to a few just key articles, Janet Turan's article in BMC Stigma Medicine on intersectionality, Lisa Boleg in AJPH on evolving intersectionality within public health and its impact on stigma thinking and stigma research. And then Mark Katzenbuehler and colleagues' article around mediators linking to stigma, which isn't a formal model or framework, but quite informative in terms of conceptual understanding of stigma. The measurement sections, again, we start off with health stigma discrimination framework around how to think about different types and levels of stigma and how to measure. We feature a webinar with Valerie Earnshaw, sponsored by the NIH Office of Disease Prevention, where she talks more of a cross-cutting conceptual overview of stigma and then how to target stigma measurement. And then we do include a couple of specific scales like the chronic illness anticipated stigma scale, the Berger HIV scale. And then for interventions, we largely link to some of the BMC systematic reviews around intervention and intervention research, as well as a description of using the health stigma discrimination framework to think about where and how to intervene to improve outcomes. Next slide, please. And so then the special emphasis tab, again, this is meant to try to think broadly, what are the general issues around this particular topic? So we start with COVID-19 stigma. We talk about the conditions for stigmatization and discrimination and offer and describe examples by different stigma types and different stigma levels with a particular focus on vulnerable populations. And we pulled that information from some of the literature that had been published to date. We also offer resources like the World Health Organization roadmap around COVID and COVID-related stigma. And then we include a link to the NIH Lit COVID, which is not stigma specific, but it's a really terrific resource if you're looking to think about searching for COVID-related research using keywords, for example. This page also then looks at frameworks, how to think about COVID-related stigma using the existing frameworks, how to apply the stigma research and publications to date to COVID. So we offer some examples from the health disparities model, and as well as the health stigma discrimination framework, offering a glimpse of applying that model to COVID-related stigma. And then in terms of measures, we offer a couple of examples of, adapting the chronic illness anticipated stigma scale for COVID, adapting the Berger HIV scale. And then we also provide a link to the published validated COVID stress scale that was available at that time. Next slide. And then, finally for the toolkit, as I mentioned, this is really a resource page. You'll see that there's funding opportunities specific to COVID-19 right at the top. And so that's another signal that, the COVID pandemic and the need for information to try to leverage lessons learned in stigma research over the years could be applied to COVID. And so this was our thinking as we were developing this toolkit, is to offer FOAs around specific to COVID. And then we will also try to offer FOAs that are specific to stigma and stigma-related priorities at NIH. And so you have at least NIMH, Fogarty, and NIDA, some links to resources that are relevant to stigma and to research for each of our institutes and centers. And then we provide contact information. Next page, or next slide. And so I'm going to pivot at this point. So, we gave you kind of the background of what led to the toolkit development. We talked about the COVID-19 pandemic. We talked about the toolkit, and we're able to hear from Brenda about some of her research as it relates to language and the study of language and stigma. And so now we just thought we would end with a view of NIMH and NIDA priorities as you're thinking about stigma-related research, whether it's in the context of HIV or other. And this is really meant just to provide you a bird's eye view of how to think about our priorities, where you might fit in, and where you might go for further information. So the Division of AIDS Research is within NIMH, and there's our vision and mission. Next slide. The Division of AIDS Research, as you may know, we are a relatively small group, and it includes basic and clinical neuroscience. It includes basic and applied behavioral and social science, all with a focus around HIV and mental health. Maybe for those of you who really don't know as much about our Division of AIDS Research, we're 100% funded through the NIH Office of AIDS Research. So all of our research and all of our priorities are really driven by the National HIV/AIDS Strategy and the NIH OAR priorities. Next slide. Next slide.
I've moved. We're on the.
Oh, you are? Okay. My internet must be unstable, so sorry, Brenda. This is just a slide to indicate that the DAR research is really from cell to society. Next slide.
Moved.
Thanks. And I just thought you might like to see an organizational chart with some pictures and some names of different program officers, branch chiefs, or our division leadership. I think what's useful about this is, you'll get to put a face to a name, and you'll get to see the different areas of research. So if you're interested in any of these different areas of research, you should always think about contacting one of my colleagues. So for example, Terry Sen, bottom right, she leads the psychosocial comorbidities of HIV prevention and treatment. And the webpage on that portfolio is a great place to get more information. Next slide. As Amy mentioned at the beginning, I still act as a program officer. I have a portfolio in HIV testing and social determinants. So both developing and testing novel approaches to increase HIV testing and linkages to prevention or treatment, as well as advancing research around stigma and social determinants. And you'll see some related funding opportunity announcements included underneath. Next slide. There is a funding opportunity announcement page for our division, and it includes all of our current funding funding opportunities, whether it's a notice of special interest or a program announcement or RFA. And maybe what I'll point to is when you look on our funding opportunity announcement page, please just look for the scientific contact. And I will make sure I wrap up soon so we have questions and answers. Next slide. This is just to let you know we do have a NOSI on stigma and other social determinants, and I'm the contact. Next slide. Another way to think, discover an institute or center or office priorities is if there's any recent publication. So a number of us at NIH banded together and we co-authored this article that was published around HIV-related stigma priorities across NIH. There's some really great resources and information if you're interested in HIV-related stigma as it applies to heart, lung, blood disease, and so on. Next slide. And this is just something for you to know if you don't already. A good place to look for kind of new emerging areas of interest is to go to an institute's council page. Usually councils meet 3 times a year, and usually there's concepts that are clear during council. And it's always helpful to look at the approved concepts just to get a signal for, are there any directions that the institute might take in terms of an RFA or in terms of some sort of funding mechanism. So I just offer the NIMH Council webpage as an example. Next slide. And on NIDA, so I can speak for NIDA extramural since I'm an extramural program officer. And so on NIDA, there is addressing stigma and health disparities page with some of the resources that Brenda was mentioning earlier, and some of the articles that have been published to date around stigma and substance use. Next slide. And then NIDA and NIMH together are on this notice of special interest around reducing stigma related to drug use. And you'll see on this NOSI that there are definitely NIDA specific priorities and NIMH specific priorities. And again, it's always useful to look at these NOSIs, and then if you have questions or interest, reach out to the person who's a scientific contact. Next slide. And so I think that ends. We would thank you, and I think we'll pause here for questions.
Great, thanks so much. This was a wonderful presentation. The research on words is just fascinating, and I really appreciated seeing the detail of this toolkit and keep thinking of all the different ways I could use it. I'd like to open up the opportunity to ask questions. People can unmute and ask, or you can write something in the chat and we can say it out loud. All right, while people are thinking of some questions, I have two that are just very operational. You mentioned the special topics or the special emphasis topic, and clearly COVID is it right now. What other topics have you been thinking that you may add in the future?
Well, the two that are the top two are mental illness stigma and drug use stigma. I think a close third would be HIV related stigma. And then I think, this is where we really are trying to expand our partnerships with some of the other institute centers and offices, and engage them and their directors. And so perhaps NCI, and maybe there will be one on cancer related stigma, for example. There's folks at NINDS around stigma related to epilepsy. There's folks at NHGRI who are interested in obesity related stigma as it relates to genomics and testing. So those are some of the ideas right now.
Great. There was a comment in the chat from Wendy Westberg. Thank you for the presentations, and words do matter. Most definitely, that was clear from those findings.
A question I can pop in and ask. I'm just, as I'm looking at the toolkit and seeing some of the literature and measures and thinking about studies that I've worked on that have used some sort of stigma measure, whether that's with HIV or cancer-related stigma, and sort of this tension, right? This push that we have in research of wanting to use validated measures, and it's good to have a measure that's been used in different settings, but also recognizing, as you've said, that stigma is so unique culturally and for different, in different settings for, different issues and intersectionally. And so I'm curious if you just have any thoughts or reactions to that, like how we can think about measuring stigma and the tools that we use.
I'm going to jump in because this has been really kind of a hard thing. Like there's certain measures that I have used and, that we all use, and new ones which have come available, but I've been trying to think of a way of approaching this a little different in the way of figuring out how stigma impacts the person and the person internally. And so I think you get the slide deck, you'll see that we're doing a study right now where we're in the process of starting it, where we're going to bring people into the scanner and we're going to expose them. Remember I picked up talking about all the stigmatizing stuff that we picked up online. Well, we have made a tool that we can run machine learning and pretty accurately to pick up social media content that is very stigmatizing around substance use. And so what we're going to do is put people in the scanner. We're going to show them high stigmatizing content, neutral, negative, and positive and negative emotion type content. And we are also exposing them physically to discomfort, to pain. And we're looking to see how that content is operationalized and manifested in the brain as compared to pain. And then we take those people and we put them, these are people who have an alcohol use disorder, but who are not treatment seeking, they're actively still drinking. And we bring them into a bar setting, we expose them to that content, and then we see, like, do they pick up the glass to drink? How, you know, what's the time delay between the content and that? The room has sensors all over. The glass has sensors to, like, you know, a gram of how much was drank, as well as time. And we can also see from the tablet what they're reading and like where their eyes are. So we're trying to figure out, you know, when people are exposed to this content, how it impacts them. The one thing that we have a big problem in is kind of some of the contents in the comments in the question answer is that we know that people who are drinking alcohol, there's a big difference between alcohol stigma or alcohol use disorder and being a drug addict, which a lot of people who use alcohol don't consider it a drug. And also if you smoke marijuana versus opiates, and if you do opiates, that is a pill form versus opiates that is in heroin form, as well as cocaine, powder versus a freebase. All of those things, they carry different, you know, I'm not as bad as that person, and different stigma. So that is like a huge limitation of the study, is that the people, when they get exposed to other substances, are they gonna even be able to relate to those people and be able to internalize it? So to answer your question, it is really hard to measure stigma, especially when you start talking about how it intersects. But I do think that we are getting better, and the best way for us to do it is to try to figure out, do psychometrics and figure out ways of better measuring it and validating it. I know that was a really long answer.
And if I could also just add, in the AJPH special issue that will be released in May, I believe that, so we do have guest editors. We are the sponsors of it. I actually don't know which articles will be in, but I have a sense that there will be an article, a systematic review around intersectional stigma measures and how to do that. And some research articles around how to think about measuring intersectional stigma, not only at the individual level, but using interpersonal and community level. And maybe the last thing I'll say, and I'll stop, you know, you might be aware of the Phoenix X Toolkit that is sponsored by NIH that tries to offer validated, reliable measures that are cross-cutting. And we met with the Social Determinants of Health group. They're doing an upgrade of their Social Determinants of Health toolkit, and they have individual level and structural level measures. And there's some discussion if there's any, you know, strong kind of general cross-cutting stigma measures. We don't really have like an everyday discrimination scale or an everyday stigma scale. We don't have something like that. But there is an effort to try to think about reliable, valid measures of stigma that could be either easily adapted or used kind of across different groups. I'll stop there.
There was a conversation in the chat, started with a question from Christina, and Brenda addressed it a bit or a lot in her comments. Christina, is there anything else to add to that, or another question that's related?
No, not necessarily. I just, well, I guess I do have thoughts. I have, in prior research, we've thought about the role of stigma in people who use drugs, and just wondered, do you have to specify, is it better to specify the kind of drug, or is it better just to use general terms, or how do you make sure that people are understanding what your question relates to? Just meth and alcohol, cigarettes, like the, you know, our team kind of struggled with figuring out what the best way to word the questions was.
I think it depends on the question. If you're asking about substance use, I think you should ask about the specific substances instead of just do you use drugs, or, but if you're asking about, Yes. Okay. So in our day and age, just to make it simple, in our day and age of computers, if a person is solely, no one is most people are not an individual one type drug. So if you can customize a questionnaire based upon input, like a person, if they select one, then you can just talk about that one drug, you can do a pathway, but most people are going to be polysubstance users. So I think it's really when you start talking about certain substances. So we typically do alcohol, marijuana, and then we'll do like a grouping of the other drugs and kind of use interesting ways of doing it. We found that alcohol and marijuana, people who use alcohol and marijuana don't typically see themselves grouped into that other group. So a lot of times we do separate them in the questionnaire for that purposes. It depends on your question, of course, like what you want to ask.
All right, any other remaining questions? All right, well, thanks so much for joining everyone, and UNC and RTI, and of course Duke, and thank you, Gregory and Brenda, for spending the hour with us. This was, I think all of us enjoyed it. We definitely learned a lot, and we'll be accessing your toolkit for sure. So take care, everyone, and thanks again.
Thank you
for having us.
Thank you.
Thank you.